Palliative care was an integral part of the Singapore healthcare landscape. Public hospitals were providing hospice and palliative care as part of the national agenda to bring hospice care into the mainstream hospital setting.
Looking at end-of-life care, it's not just about the disease. It's a lot of psychosocial, emotional factors, relationships, things of which may not be aware of as healthcare providers, that we gently need to help patients journey through their last phase. We were still working with Ministry on some of these things under this NSPC, National Strategy for Palliative Care. I was chairing it. The drivers are my colleagues really. The first thing we needed was dedicated staff. We need to have dedicated spaces. Then we must think in terms of how do we train another generation. Then we have to think about how do we train specialists as well as train GPs in palliative care. My colleagues who got interested in palliative care are a self-selected group. They are people who really want to be involved. On the other hand, in palliative care, sometimes you also need people who are very strict about attending to details.
Many of the initial people who helped the hospice fraternity were not, in that sense, palliative care people, because remember, palliative care is a relatively young discipline. One of the earlier volunteers were people like radiation oncologists, anesthesiologists, psychiatrists, and they were not, in that sense, doing palliative care full-time. And hence the ability then to work with these groups really did move the palliative care scene ahead.
I think palliative care is special because it needs a blend of both the science of medicine as well as the art of medicine. The science of medicine is important because as palliative care clinicians, we need to know what type of cancer the patient has. We need to know about all the different end-stage organ failures and how fast it will take the patients. So this is knowledge and the science that is critical to a palliative care clinician. But then of course there's the art side as well. The art side is many times communication with the patients and families. It's being able to sit down and to be able to draw out what are some of the concerns and worries that patients and families have during this very, very trying and difficult time. And at the same time to be able to offer them that comfort as well as that hope, but yet also to be realistic with them as well in terms of letting them know how much time they may have and what are the things they can do or what are the things they can't do. Yeah, so that is what I think makes palliative care a specialty that is different from the rest of medical specialties. We had a situation where we had a mother who was dying of breast cancer, and she had a son in late 20s with severe autism, but he was very, very attached to the mother. And so we were very worried what would happen to him after the mother died. So our art therapist actually did a thumbprint onto a piece of clay with the mother's thumbprint, and after that made it into a necklace and gave it to him. And she told him that your mommy will always be with you. Then when our social workers and art therapists visited the wake after the patient had passed on, we saw the son. He was wearing the necklace. The multidisciplinary team is truly important in the work that we do in palliative care. That is not just the doctor does all, because the doctor truly cannot do everything.
So this is a job not for one person. We need a nurse, we need a social worker, we need counselors, we need volunteers, we need physiotherapists or music or art therapists. So that's the multidisciplinary team that brings a whole, I would say, buffet of offerings to our patients and families, so that individually, if they have any aspiration, any hope, any wishes, we would be able to kind of support them or fulfill them. We were able to find out one particular patient very, very much loves to compose songs. And then we were able to put music therapists with the child and the family. In this instance, it was a child. And we were able to help the child compose a song in the short period of about 2 months-ish, record the track and an MTV. And we were able to kind of release it to the child just before the child died. The child was so delighted. Although she was in a lot of pain, she was able to actually smile when she saw it. And then what she said to the parents was really critical. And I remember to this day, I want you to remember me this way.
Palliative care is really trying to meet the needs of the patients and their families. And the needs of patients and families are not just the medical needs, they are the psychosocial needs. And there are many other needs, such as spiritual needs as well. So which is why it really needs that whole person approach and the whole multidisciplinary approach to palliative care.
A very important thing about the nursing people to hold on to is basically on this thing called the humanistic care. And also the person-centered care, that you treat this person as a person, not treat this person like you have a condition. Respect the person as a whole. You have to follow them through the journey. You have to be with them throughout, listen to their stories, what they want, and give them to the very best, to the very end.
And they have many touch points to reach a patient at the front line, to witness the needs and to bridge the care gaps. You don't have to be extra special. You don't have to be super trained to love a person and care for a person sincerely. You just have to be yourself, and your presence can make a difference in a person's life. Everyone is happy, excited to see your newborn, right? When someone is departing, right, offer that same kind of respect, love and care.
Medical social worker, we really look at the psychosocial and spiritual dimension of the care that we provide. We really work with the patients and families within the context of a therapeutic relationship, and really to address some of the challenges they face, even in the midst of a life-limiting illness. So it's really very crucial where the multidisciplinary teams come together to really discuss the goals of care, to really look at what's important for the patients, right, and to sort of shape care together and not separately.
I was trained as a in-ward palliative care volunteers, so I do go to hospice in-ward to support the nurses and engage with the patient, so I can be an extra pair of hands to help them to do some of the simple chores. At first, I'm not even sure I will make any difference in people's life, but very soon I noticed that even small conversation can touch people's life. And I found that very rewarding, especially caregivers share that they felt that they are less alone.
Spare no efforts to deliver it for them, because this is their one passageway to a very good place, and hopefully that process leaves a nice memory for the ones who they leave behind.
We want to create moments, because in creating moments, it's not just good experience for the patients. The caregivers, their family members, when they look back, what do they remember? They remember the moments that have been created to make the experience of otherwise a sad time meaningful, the sad time enriching.
At its core, palliative care is about people, kindness, respect, and being there until the very end. Today, this holistic approach is firmly rooted within Singapore's healthcare system and the community, a testament to the Singapore Hospice Council's enduring commitment and collaborative efforts. As our society matures, so too does the call for more compassionate, personalized care. And behind this evolving landscape, the Council's powerful work continues to shape the future of end-of-life care.